Uh, for the third talk, I just like to call Dr. Ashish Jaiswal, DM in cardiologist from Varanasi. The topic is resistant hypertension from diagnosis to treatment. Over to Dr. Ashish.
Thank you, chairpersons and organizers. So this is I think, quite lengthy topic. I would like to touch upon interesting or important clinical clues that how we should be approaching to a patient with resistant hypertension. By definition, as we all know that if we have a patient of hypertension where we are not able to achieve the goal with three medications, one of them being a diuretic, and if patient has to be on optimal doses, the maximum tolerable doses is not included in the definition. And any patient who requires more than three medications, suppose we have a patient who is controlled on four drugs and still this patient is of resistance hypertension. Why it is important? Because these are the patients who needs to be more closely monitored, and if these patients lose the control, we are going to see them in accelerated hypertension or hypertensive urgencies, emergencies. So just this is a slide showing ESC 2024 guidelines for non-elevated, elevated and hypertension. That is 120/70, less than 120/70 is non-elevated. Elevated is 120 to 139, and if blood pressure is more than 140 systolic and 90 diastolic, it is diagnosed as hypertension. So before we go to diagnosing a patient as a resistant hypertension, uh, the prevalence is around 10 to 20%, and there are conditions where actually there is not a resistant hypertension, but there are factors responsible that blood pressure is not controlled. So that situation we call as pseudo-resistant hypertension, and the common things are poor drug adherence by the patient, improper techniques of measurement like white coat hypertension, or many a times other factors are there. And when we talk truly resistant hypertension, then there should be patients who are resistant despite of lifestyle modification, and other causes might be related like drug related causes, and secondary causes of hypertension might be there. So poor blood pressure measuring technique is one where patient comes to your office and you measure a blood pressure is high. This may be because of apprehension, because of white coat hypertension, or because of inappropriate measuring technique. So firstly we should confirm that this is in true resistant hypertension. Another important thing is poor adherence. The part of country where we are practicing, we don't know that whether we have what doses and the medicines we have prescribed patient is actually taking that or not. So before labeling a patient as a resistant hypertension, you should take out time and see that what medication he is taking, in what doses he is taking. It might be possible you have written him 40 mg of olmesartan, and he's in taking a prescription with a 20 mg of olmesartan, because pharmacists also replace the medicines. So this adherence is very important thing, and if this uncontrolled blood pressure is because of poor adherence, this is not a resistant hypertension. And white coat effect we have discussed because of apprehension to visit to a clinic. And if you talk of contributing factors, we have drugs that like steroidal group of drugs, non-steroidal drugs. We have patients who are on erythropoietin, patients who are taking oral contraceptives. These are the confounding medications which might be reducing the effect of antihypertensive therapy. Then patients who are taking excessive alcohol intake, volume overload conditions, patients, we have other conditions like obesity, diabetes, and very old age patients. And then we have identifiable causes for which we will go into detail in coming slides. And if we these are one of the important conditions that we may address, like obstructive sleep apnea, primary hyperaldosteronism, renal arterial stenosis, CKD, which is one of the most common condition which we are seeing as a resistant hypertension. Then we have drug induced or heavy alcohol use and thyroid disorders. So these are some conditions. And if you talk of obstructive sleep apnea, this can be easily diagnosed within sleep study. Then we have primary hyperaldosteronism that may be responsible up to 20% of patients of resistant hypertension, and diagnosed as an aldosterone and plasma renin ratio of more than 20. Then we have renovascular hypertension, any patients who are young, and we can diagnose them with the Doppler renal ultrasounds. Then for renal arterial stenosis, we have two groups. One is fibromuscular dysplasia, another is atherosclerotic renal arterial stenosis, and it is seen in patients who have fibromuscular dysplasia. They are more available to treatment like renal arterial angioplasty in comparison to atherosclerotic for controlling blood pressure once it is diagnosed as a cause of resistant hypertension. Then we have renal parenchymal disease, that is CKD, one of the most common cause of resistant hypertension. And if you see that how we should be approaching to a patient as in resistant hypertension, the very first thing is confirm your diagnosis. That, and for confirming ambulatory blood pressure is the most important tool that should be taken, because you should see the adherence and you should see the ABPM reports, and 24-hour ABPM is helpful in much more ways other than you will know the pattern, you will see whether patient is dipper or non-dipper, and many other things, informations that rate control, how the diurnal variation of the blood pressure is there, all that information is there. And OBPM is an easily available tool. So before labeling a patient as a resistant hypertension, we must have a ABPM data. And once we have confirmed that this patient is having resistant hypertension, that is clinical blood pressure is more than 130/80, taking 3 or more medications, then when this condition is done, then we should be confirming our adherence. And this, as we said, that we should have in data 24-hour ambulatory blood pressure. And then we should be screening for the secondary cause of hypertension like primary hyperaldosteronism, renal parenchymal disease, renal arterial stenosis, pheochromocytoma, Cushing syndrome, obstructive sleep apnea, aortic coarctation, and other endocrine causes. And at the same time, it's also important to assess the target organ damage, because if patients who have resistant hypertension and they have evidence of target organ damage, these are the patients who have in more urgent need of control of blood pressure, and that the evidences are retinal damage, that is retinopathy, ventricular hypertrophy, patients who are having proteinuria and reduced GFR, and patients who have peripheral arterial disease in the form of raised ankle brachial pressure index. So these are, if we are founding these target organ damage in a patient with resistant hypertension, this is a more alarming patient in whom we had to be more cautious and more rigorous in diagnosing and controlling this resistant hypertension. And role of ABPM we have discussed, that if ABPM data is one of the cornerstone in diagnosing resistant hypertension, and if 24-hour ABPM data suggests that BP is more than 130/80, then this patient needs to be addressed, labeled as a resistant hypertension, and should be taken care of. So this is how ABPM data is managed. So once we have diagnosed the case, then how we should be approaching? The first step is ensure low sodium intake and maximize the lifestyle intervention, that is weight reduction, adequate sleep, increasing the dietary fibers and fruits, and advocating exercise. Because we know that lifestyle intervention, if they have advocated, they can reduce the blood pressure by 20 millimeter of systolic and 10 millimeter of diastolic. So this is, instead of adding another drug, advocate and see that whether patient is taking more of alcohol, more of tobacco, not adhering to the lifestyle modification, and that should be taken into consideration. And the second step should be optimizing the diuretic dose, because this might be a patient who is diuretic resistant, and the dose that you are using as a diuretic might be suboptimal. So you may opt to choose a BD dosing of short-acting diuretics like furosemide, or you may take an OD dosing of long-acting diuretics like torsemide. And if even after adding this, up-stepping your diuretic, you are finding at a 2 to 4 week interval that BP is not well controlled, add the third drug, that is mineralocorticoid receptor antagonist. So better is that we have all combinations of one of diuretic, that is loop diuretic or thiazide-like diuretic with spironolactone. So adding that drug is the first thing that, in my opinion, that we should be doing. After third drug is in combination of furosemide plus spironolactone, in a OD or BD dosing or in divided doses. That will be the best approach to addressing these patients. And if still these patients are not on control, then we should be taking them whether this heart rate is optimally controlled or not, and if it is not optimally controlled, we should considering beta blockers. And if in choosing beta blockers, the dual blocking beta blockers who have both alpha adrenergic and beta blocking effects, that labetalol and carvedilol should be a preferred beta blocker when we are using beta blocker as a fourth agent for controlling blood pressure. And still if it's not controlled, then we can go for a hydralazine, and if it's still not a control, we can go for other drugs like minoxidil and other agents. So this is about this control of lifestyle modification. We see that each intervention reduces systolic blood pressure by 5 and diastolic blood pressure by 2 to 3. So if you strictly apply the lifestyle interventions, we are going to reduce the blood pressure in these resistant patients. And if you talk of pharmacological treatment, as we discussed, the fourth line of drug should be a diuretic with mineralocorticoid antagonist, and ABPM should be a good guide for seeing that when we have to add this drug, night times, evening, or daytime. Then if you talk of the drugs which we have for resistant hypertension, diuretics, we have multiple options. Then we have calcium channel blockers, then we have angiotensin receptor blockers, ACE inhibitors, then we have fourth line agents like mineralocorticoid receptors. Fifth line agent should be in direct renin inhibitors. And then come the role of beta blockers, and after beta blockers we have other vasodilator drugs like hydralazine. We have newer drugs which are there, and some of this was discussed by Dr. Akshay Pradhan also. This Baxdroxstat, that is in pipeline. Then we have aprocitentan, and we have gileberisan. These are the drugs which are still in pipeline, and we might be able to see them in future for our clinical practice. So after the drugs, we have interventional management, and for interventional management, we have renal arterial stenting is one, but the role of this intervention is not very well approved. Still, it is approved for those patients who are on optimal maximum tolerable medical therapy. Still, we are finding renal arterial stenosis, and blood pressure is not controlled. Then we may go for renal arterial angioplasty. And another is renal denervation therapy. This therapy is basically destroying the renal denervation, which destroys the sympathetic surges from the renal artery to the systemic systems. And this is a catheter based therapy which ablates the adventitial neurons. And we have now the simplicity 1 and simplicity 2, where the studies where we found encouraging results, but the simplicity 3 was a failed study when this was randomized. But still we have recent data where this is being advocated with the newer devices like simplicity spiral radio frequency renal denervation system, which is approved by US FDA, and it is available in India also for use on resistant hypertension patients. But these are the therapies which has to be advocated in those patients where we are using 4 and 5 or 6 drugs, and still we are not able to control them. Another is carotid sinus stimulation, that is a pacemaker like thing, where we implant a stimulator in both the carotids, and pacing this device is shown to have reduction in the blood pressure. So these are device based therapies. So if we conclude the things, that diagnosis of true resistant hypertension is important, and when we are seeing these patients, adherence is very important thing, because in our part of country patients are really taking medications by their choice. You may be prescribing 3 drugs for antihypertensive, and they are thinking that this one medicine is more suited for me, and he goes with that. And unless you cross examine them, you will think that I am giving 3 medicines and patient is still not controlled. So please verify it manually that what 3 drugs you are taking. Unless that you do, it's difficult to. And another thing is counseling and convincing your patients, those who are not compliant, that if you are taking medications for blood pressure control, and if it's not controlled, then you are bound to get the side effects and the secondary harmful events like CV outcomes, adverse renal outcomes, and stroke, despite you are taking the therapy. So the counseling part is also important. Then we have drugs. The first drug that should be added is optimized diuretic, that is up titrate the diuretic with aid and spironolactone or any other epinephrine as a middle cortical receptor as the first drug, fourth drug to any patient who label you as an resistant hypertension. And then we have other options. And if you talk of intervention based therapies, renal denervation therapy is coming out, and we in future we may see this therapy for especially those patients who are really tough to control even on 5 or 6 levels of drugs. So that is all with this my talk. Thank you.
Thank you, Dr. Ashish, for your wonderful talk. And now the session is open for the audience for the questions. Any questions from the audience?
Dr. Ashish, what is about replacing ACE inhibitor and ARB with ARNI in
Yes.
few cases of hypertension before labeling them as a resistant hypertension? Because in some instant I had seen that patient taking ACE inhibitor, calcium channel blocker along with low dose diuretic, BP is not controlled. But when I replace ACE ARB with ARNI, then blood pressure readings comes down and it becomes normal.
Yes, we have this. I also have seen this in my practice also, that adding an ARNI improves both two things at the same time. It reduces the pill burden also. But I always give this with an diuretic combination, that is furosemide plus spironolactone, because that aids better. That is a good thing that can be
I think
practiced.
there are some small studies with the use of arni in resistant hypertension as a drug in resistant hypertension, and they have also shown some promising results that arni itself can reduce blood pressure more than even ACE inhibitors or ARBs. So
Yes.
somebody who is having a heart failure with improved ejection fraction or something with a hypertension, I think would be a good candidate
Yes.
to
Yes.
start a
Yes.
arni. What about the role of how important is hyperaldosteronism once you are treating resistant hypertension?
So if you see in our part of country, we hyperaldosteronism is generally said that you detect an hypokalemia, but every patient doesn't every patient of hypokalemia may not be the only indicator. So when you are suspecting, it's important to see this aldosterone renin ratio. If it is more than 20, then you should proceed further for CT scan to see how the adrenal glands are there, and whether it is multinodular or it is single nodular, because those patients who have single nodular CT images, there are more chances to have primary hyperaldosteronism. So this is a common thing, and data says that 10 to 20% of patients of resistant hypertension might be having hyperaldosteronism. But hypokalemia is not the only guide. If you have you should have a high index of suspicion, especially those patients who are young. Thank.